Greetings, everyone, and welcome to the EKG case for the week of March 4th, 2013. Before we get started, just another plug for a great conference coming up in Las Vegas, May 1st through May 5th, 2013. There's the website that you see down there, and if you want to get some more EKG training and a lot of other resuscitation training, check out that conference. Okay, on to the case this week. This week's case was sent to us by Dr. Rene Verbeek, and I hope I'm pronouncing his name properly. He's an emergency physician out in the Netherlands. He and his colleagues were taking care of a 50-something-year-old woman who was found at home unconscious by her daughter. The daughter came with the patient, fortunately, because the patient's unable to provide really any history at all. She's got a GCS of 3, which is almost screaming for an intubation at this point when I see a GCS of 3. But anyway, her airways seemed to be intact. There were no apparent secretions pooling at the back of the throat. Her respiratory rate is very concerning. And when we see somebody who's obtunded with the respiratory rate that is that low, the first thing we here in Baltimore are thinking about is opiate or narcotic intoxication. In this particular case, the pupils were mid-sized rather than pinpoint. They were sluggish. Other vital signs, blood pressure seemed to be okay, glucose okay, heart rate a little fast, and I think the pulse ox, I don't have that, but I think the pulse ox seemed to be okay. But anyway, with a patient like this, we're probably going to get our airway equipment as we continue the initial evaluation. Now, the daughter is there, and the history that she provides is that the patient's chronically on 2 benzodiazepines, chronically, now that is, and the patient's had a decreased level of consciousness since yesterday, and it wasn't until today that she got brought into the hospital. So what kind of things are you thinking about at this point? You know, if she had pinpoint pupils, we'd certainly be heading right towards the naloxone. But she's on 2 benzodiazepines and she's obtunded. Should we be giving her some flumazenil to wake her up and perhaps avoid an intubation? Or do we just do supportive therapy? Maybe intubate her, get a quick CAT scan, get every lab test in the book, and just admit her to the unit. What are you going to do in this case? Well, here's a hint. This is an EKG video series, right? So the first thing we're going to do after she gets IV O2 monitor and 12-lead IV O2 monitor is to get a 12-lead EKG, and here is the 12-lead EKG. And although in the Netherlands, I think they call it the ECG, which is more appropriate, I'm sure. So anyway, here's the 12-lead ECG, and right off the bat, I'm sure many of you are noticing some concerns here. And we're going to take a stepwise approach as we go through this 12-lead EKG because there are a bunch of abnormalities that are worth highlighting. We've talked about this approach before, the 5-step approach. Many of you have a similar approach depending on whatever book or person it was that taught you how to read 12 leads to start with. But I like to start with the rate and rhythm right up front. Let's go back to that 12 lead. The rate's about 115, 120 or so. And the rhythm, well, there's no really clear-cut P waves in the leads we normally look at, V1 and lead 2, but you always look in all 12 leads when you've got 12 leads. Look in the rhythm strip also, there's your 13th lead. And at least in a couple of leads out here laterally, we do see nice P waves, so we're going to go ahead and just call this sinus tachycardia, all right? So we'll call this sinus tachycardia. And we also, next step would be the axis. We're going to say that there's a rightward axis. Let me go back in case you didn't get a chance to look at the axis. The QRS is probably mostly upright in AVF and definitely downwards in lead 1, so that makes this a rightward axis. And as we said before, when you go through this 5-step algorithm, every time you come up with an abnormality, you stop and you think about the differential. So let's talk about the differential for rightward axis. And once you get good at this, once you get to know these differentials, this really doesn't take long at all. I'd say about a minute or so, honestly, if even that long. Here's the differential for rightward axis, and you just go through these things and you just knock them out one at a time. You know, misplaced leads, for example, the first thing you do, just check to make sure that the leads are properly placed. All right, and they were, so we're going to cross that out. Hyperkalemia, well, is there any peaking of the T waves? There's really not. So tell you what, let's get rid of hyperkalemia. There's no ventricular ectopy. This isn't ventricular tachycardia. Pulmonary hypertension and right ventricular hypertrophy you can probably put together. That usually gives you a tall R wave in V1, and we really don't see that. So tell you what I'm going to do is I'm going to cross these off. Lateral MI, that means if you see giant Q waves in lead 1, and probably in L also, but in lead 1, that's going to give you a rightward axis. In this particular case, there are not giant Q waves. There's actually little S waves, and then little R waves, and that means that this is an S wave. So these are not giant Q waves, and therefore we can cross lateral MI off, and that leaves two possibilities: sodium channel blocker toxicity as a cause of rightward axis, and left posterior fascicular block. Left posterior fascicular block we've talked about before. Rightward axis, you get little r, deep S in lead 1 and AVL, and in lead 3, little q, big R in lead 3. And so this could meet definition, could meet criteria for left posterior fascicular block. So fine, we'll go ahead and we'll leave that on the differential. So we've got the rate, we've got the rhythm, we've got the axis. We've identified an axis abnormality, so we've gone through the differential, and it appears that one of these two is at hand. So right off the bat, you see that we've taken this 12-lead EKG, which has a handful of abnormalities, and we've already narrowed the differential all the way down. See, 12-lead EKGs are really, really easy once you start thinking about differentials. But we're not done. We've got intervals and ischemia infarction. What about the intervals? Well, there is a wide QRS. It's slightly wide. And there's also what appears to be a somewhat prolonged QT. And I think you can really appreciate the prolonged QT in the inferior leads. That's a fairly long QT interval. So we've got, and the PR interval seems to be okay. So we've got two interval abnormalities, wide QRS and long QT. You've got an abnormality there. So let's stop and talk about the differential for both of those. What's the differential for wide QRS? Well, hyperkalemia is on the differential for everything. So we're going to consider that, but we've already knocked that off. There's no evidence of delta waves and short PR, so we can cross that off. There's no bundle branch block, left bundle or right bundle, so we'll cross that off. There's no VTAC, there's no pacemaker. There's medications showing up once again, and then there's this wastebasket term, non-specific interventricular conduction delay. That includes things like LVH, hypothermia, and other things when you just don't know what the cause is. So, well, there's still a couple possibilities here, but we've been able to knock these things off, so we're going to talk now about the differential for a long QT. There is a long QT, so here's a differential for the long QT. Hypo-K, hypomag, hypocalcemia. Honestly, you need to get lab tests to evaluate those. Elevated intracranial pressure certainly is a possibility in this case, so we're going to keep these on the differential. Sodium channel blocking medications is showing up once again. Hypothermia. Well, you know what? You can rule that out with this thing called a thermometer, so we can probably rule that out. And then congenital, which is usually in younger patients, and then acute cardiac ischemia. But we didn't really see any signs of, we skipped over that, but we didn't see any signs of ischemia or infarction on that 12 lead, so we'll get rid of that. So as you can see, there's one thing that's come up in every differential that we've talked about, and here it is, sodium channel blocking medication toxicity. So we'll move forward, and what are the things that are suggestive of sodium channel blocker medication toxicity? Well, there's the rightward axis deviation. There's also the sinus tachycardia. There's the long QT. There's the wide QRS. And there's one other abnormality which we really didn't talk about, but there's a tall R wave in lead AVR. And when you see a tall R wave in lead AVR, you think about misplaced leads. And one of the other possibilities that you've got to think about is tricyclic or sodium channel blocker medication toxicity. So just by going through these differentials, you arrive at a diagnosis very quickly. If you don't go through the differentials, you might sit there and stare at the 12 lead and not come up with the diagnosis. But you go through the differentials, you come up with the diagnosis very, very quickly. and everything's pointing towards a tricyclic or other sodium channel blocker toxicity. Treatment here is going to be sodium bicarb, and especially if you're considering tricyclic, one of the therapies we mentioned earlier, flumazenil, you definitely do not want to give this patient. There's case reports of patients getting flumazenil who had who had tricyclic overdose, who went into intractable seizures. So again, you just go with the sodium bicarb. Little follow-up on the patient. It did turn out, and again, we've talked about the 4 or 5 things that you normally see with a tricyclic overdose. Use your differentials. The follow-up on this particular patient was that they did a drug screen, and they did indeed find that the patient had a significant overdose of a tricyclic antidepressant, and so the therapy with the sodium bicarbonate was appropriate. All right. So kind of I think a fun case. Honestly, when I looked at that 1280 kg, the diagnosis didn't jump out right at me. So what I did, I just went through the stepwise approach, and suddenly things became very clear. As you go through those differentials, the one possibility that produces all 3, or that shows up in all 3 of the differentials we talked about, is sodium channel blocker toxicity or tricyclic antidepressant toxicity. So it's kind of fun when your differentials actually give you an answer, and that's why it's useful to think about those differentials when you go through this. So I hope that was helpful. I hope that looking at the differential for right axis deviation, looking at the differential for wide QRS and also for long QT, I hope that's helpful. Put that in your back pocket, and whenever you see those abnormalities on a 1280 kg, just stop for a second and run through those differentials. You'll be surprised how often, just like in regular medicine, how often thinking about differentials helps you arrive at the answer. So, fun case. My thanks once again to Dr. Verbeek for sending a great case that we can all talk about. And I look forward to talking to all of you next week. Bye for now.